Hello, everyone. Welcome to our debate. Our topic is restraint and seclusion, and we will start by introducing ourselves.
Hi there, my name is Alex Bielish. I'm from Chicago, Illinois, and I have around 4 years of experience in the field of ABA.
I am Brittany York. I live in Indianapolis, Indiana, and I have about 2 years in ABA in the clinic and school settings.
My name is Hannah Kolbeck, and I live in Pittsburgh, Pennsylvania, and I have about 2 years of experience working in ABA as an RBT.
Hi, everyone. My name is Heather Markowitz. I am a BC ABA with about 10 years of experience in the field, and I'm currently living in Washington, D.C.
Hey everyone, my name is Allison Bryant and I live in Houston, Texas. I currently have 3.5 years of experience working in a clinical setting.
So we'll jump right in. I'll just give a brief overview of all of the topics that we're going to be discussing with regard to restraint and seclusion. We're going to be going over different ways to define restraint and seclusion, the effectiveness of restraint and seclusion, the risks that are involved, as well as the different alternatives to restraint and seclusion.
And so the style of our debate will be pretty informal. We will have main topic questions that will be structuring the debate throughout, and then we'll provide research that supports specific points. And then we will just open debate up to the larger group.
All right, so the first question that we're going to start with is, how is restraint defined? What are the types of restraint and which are most ethical to use?
So the law dictionary provides a legal definition of restraint as prohibition from action or holding or pressing back action. What do we think of this?
So that definition feels a little bit broad. It makes me wonder about, for example, if a baby gate would be considered a form of restraint. Or what about using a protective mat to block aggression, or maybe even an instance in which a child wears arm guards to protect himself against self-injury like arm scratching?
So the way I've often seen it broken down to maybe further define restraint is by categorizing it into 3 categories, which is mechanical, chemical, and physical. And we see a visual here of that. Mechanical restraint we can see is like a straitjacket or some object that is restricting movement. We see physical restraint, another person restraining another person, and then chemical, which when chemicals are used to subdue behavior. So when we think about a baby gate, that is like an object that is restricting movement. It may be more like seclusion because it's restricting movement in a certain area. And seclusion has been likened to a mechanical type of restraint. When we think of something like protective mats, it kind of depends on how it's being used. If you have 4 people blocking a person into a specific area, that might be more like seclusion or mechanical restraint. But if you're using your body pressure to push against someone else, then it might be physical restraint. However, there is another visual here that shows the types of restraint and how often they are used. We can see here that physical, not prone restraint is the most common, followed by an unknown type, followed by physical prone, which is like a floor restraint. And then chemical is actually the most used after that. And seclusion and mechanical are broken into 2 categories here, but they are very, they're the least common type of restraint used. So it is debated which of these types of restraint are the most ethical. What do we think?
So I just wanted to jump in with a legal definition of restraint, and as it's legally defined, a lot of schools would consider it corporal punishment. So that's, kind of can factor into how ethical we think it could be to be used. Legal advocates and legal standards consider it corporal punishment, and they define it as any punishment in which physical force is used and intended to cause some degree of pain or discomfort. And we know just from the ACLU that corporal punishment is allowed in 20 states, but it's increasingly acknowledged nationally and internationally that it is unethical or abusive or a violation of children's human rights, mostly because it's found not only to be harmful, but also could lead to an erosion of mental health and can also sometimes lead to an increase of aggression rates and violence and other problematic behaviors.
And I know the BACB ethical code states that we should always be using the least restrictive alternative. The ABAI is also opposed to the use of seclusion, and they define that as saying when someone's locked into a room, often combined with use of mechanical restraint or sedation. But the BACB and the ABI is stating that, we need to make sure we have parent consent when we're using this, and it's part of a behavior plan, as well as having the individual consent if that's an option. So I kind of guess I would say, like, locking someone in a room alone doesn't seem to be a safe option or a least restrictive option. Do you think that we can all agree that physical or other mechanical restraints should be chosen over seclusion whenever possible?
I think it really depends on the environment as a whole and the behaviors utilized by the individual. As long as an individual can stay safe, as long as other individuals in the environment can stay safe, yeah, I think it works well. Even though seclusion isn't used as much, I think it really depends on the situation.
I do think that's true. I kind of originally thought that seclusion seemed to be one of the most restrictive options. But I did find some research. There was a randomized control study by Steinert, Burke, Flammer, and Berg in 2013 that actually showed that seclusion produced less PTSD symptoms than other forms of restraint. They compared it to mechanical restraint. So I found that to be surprising. Also, we know that physical restraint is known to cause injury and even death in some cases. So I would propose that maybe seclusion is the less restrictive option.
Right,
Yeah.
that definitely is a good point. But I do know, on the other hand, we have seen that physical restraint could be possibly less restrictive because it can actually be more therapeutic. And I know, looking at some of the research from PCM, which is a restraint training system, they stated that the feedback provided through intensifying or lessening holds over time can actually help to shape desired behaviors for these individuals. So the child will begin to learn what to do, what not to do, what consequences are going to be applied, and it'll allow them to understand how to remove themselves from that restraint in a safe manner over time. So I think it really just depends on the individual and the system used and the level of learning for each child.
Yeah, I wanted to jump in. I was going to say that when I was living in Boston, I got to take a tour of a particular ABA school that had designated seclusion rooms that were actually really awesome. And it kind of changed the way I thought about seclusion, sort of like Hannah was saying. They have these like very safe rooms with windows like in the door, and the teachers or the staff would have to be standing and like looking in the window, and they had to keep their hand on like a little sensor pad in order to lock the door. So unless the child was being observed visually, the door wouldn't be locked. And like, so it was just like all these really neat safeguards to ensure that the seclusion was also therapeutic and being done in a safe manner, and that there was all these safeguards in place for that. So that kind of changed my mind also to say that maybe seclusion isn't always necessarily like the least restrictive option because, as she mentioned, there's some risks involved with mechanical restraints.
Right. So there may be disagreement in deciding if physical restraint or mechanical restraint in the form of seclusion is least restrictive. However, though, chemical restraint could be considered the most restrictive.
Mm-hmm.
Some issues with chemical restraint could include, staffing and medical resources, negative side effects, or even overprescribing.
Right. So it seems like we have a lot of research on various fronts here, trying to figure out which one is the most restrictive, which one is the least restrictive, what are the differences we see in each situation within the use of these restraints. So, I know we talked a little bit about personal experience with the padded rooms for seclusion. Does anyone else have any other experience that they'd like to talk about in regards to what type of restraint is the most restrictive or the least restrictive?
I guess I have some questions about chemical restraint just being the most restrictive because of the long lasting effects. At least with seclusion and with those physical restraints, we have the option to end those at any time. Whereas chemical restraint, once that chemical has been introduced, let's say that the person has a negative response, we can't just take it back. And,
Sure.
you know, in those other types of seclusion and restraint, at least we can say like, hey, this obviously like isn't working right now for this person. And we kind of have that option to end it right then.
Yeah, I would agree with that.
Sure. So that versatility really puts, something that can be utilized more effectively. Okay. So, I think there's still a lot of questions that we may have about which one is most or least restrictive, and it's just really depending on who's in the restraint, what environment you're in, and I know we're going to touch upon some specifics to environments later.
Yeah, I would say that kind of leads us into our next question about when restraints and seclusion can be found effective.
Sure. So I know we had a lot of research on the effective training, specifically talked about PCM earlier, and we know that there's a variety of clinical organizations that utilize restraint and or seclusion training programs to ensure the safety for staff and clients. That's really the core centerpiece of these trainings. So they typically have a focus of de-escalation techniques, and they typically have the use of restraints as a last resort, again, just really connected to the safety of clients. And I know CPI is a really large restraint training program that is really well known, and there's others like Handle with Care, there's PCM, TCI, trauma crisis intervention, and this really connects to ethically utilizing the least restrictive treatments in different settings, whether it be home or clinics. And in connecting to that, I know the ABAI supports the use of restraints and seclusion when they're ethically planned, predetermined, consistently monitored, and consented to. So these are all really important core pieces of using restraints and seclusion.
Yeah, and additionally, I know that there is some research that shows that restraint methods that are effectively trained, closely supervised, and analyzed by data to evaluate clinical effectiveness can be effective and, in their opinion, the most ethical.
Right. So I think it really shows that, it can be really helpful in these settings. And we have a visual here from the CPI about restraint reduction. So after the training from CPI, utilizing not only restraints, but also de-escalation techniques, they're seeing a reduction in the use of restraints within school programs. This is within the Aspen program. And we're seeing the differences in school years, 56% to 18%. It's a really big drop in a school setting. And we're also seeing, in addition to that, we have another visual connected to using it in healthcare as well. So since they implement training, they're seeing a decrease in physical restraint and seclusion overall. So we're seeing that these trainings can actually help to reduce the fact that restraints may not always be needed, right? There are other applications that can be used in lieu of the restraints.
Other than just training, I think that procedures being placed by the company that is having their staff use restraint and seclusion is really important. Cal's talked about setting time limits, specific procedures and definitions of when restraints or seclusion should be used was a really effective strategy. Also, just having reporting procedures in place was shown to decrease the number of overall seclusions and restraints needed. So kind of tying in with that, training being really important, just having those clear definitions and expectations, potentially setting time limits on using those things, that was also found to decrease the number of restraints and seclusion. Another piece of information that I just found really interesting was training staff in other things besides restraint and seclusion. So being able to use other interventions was another thing that they found reduce the number of restraints and seclusions with having other appropriate strategies such as token economies and skills groups in place.
So there definitely seems to be a connection between, how CPI and other training systems are working through, de-escalation using other things, like you said, like token boards. It's allowing staff to be more versatile, and it actually reduces the amount of restraints and seclusion over time, which is pretty cool.
Yeah.
So I know we have a study that I think we researched here. Heather, was that something that you wanted to talk about? I think your mic's muted there.
Sorry, guys, my mic was muted. So I definitely wanted to talk about a study by McDonald and Sturmey from 2000, where they were looking at the social validity of different sorts of restraints. The reason that they did this study was because physical restraints can be strenuous, emotionally arousing, and difficult to maintain. So they wanted to see, is there certain restraints that we find to be more socially acceptable or socially valid. So in their study, they were comparing floor versus chair restraints, and in relation to like how accepted the interventions were. So participants would view videos of 2 floor restraints and 1 chair restraint, and then they would complete an evaluation to compare the interventions that were used. The participants included many different people, but special ed professionals, residential care staff from a hospital setting, high school pupils with no experience in developmental disabilities. So they really got like a nice range of people to do these evaluations. They found in their study that the chair restraint was judged way more favorably than the floor restraint. And these findings were consistent across the 3 participant groups that they worked with.
Right, and I know what's important, how we talked about earlier, the difference of like mechanical restraints with this study, it was just individuals holding the clients down. So there was no mechanical straps or arm bars or anything, it's just staff members holding individuals down. So it's really interesting to see that they picked the chair restraint more favorably than the floor restraint in this case.
Yeah, so I guess that brings up some questions for me about like how our group's opinions vary on physical restraints and their effectiveness. Kind of like, what do we think about floor restraints versus chair restraints, and how does that impact social validity?
That's actually really interesting. I was surprised to learn that they found chair restraints to be the most socially valid. I personally don't have experience with chair restraints, but I have experience with other restraints. And my first impression is that I would find chair restraints to be dangerous, possibly. I mean, you have immovable, like unbendable objects that you're kind of using your own force with. I guess I would just think that that would possibly pose a threat, a risk of danger.
Yeah, I do
injury.
have experience with both floor and chair restraints. And to me, I kind of thought that chair restraints, that made sense to me that they were judged more favorably in the sense that you have a little more control of the environment, it feels like, when you have a chair restraint. The client doesn't tend to move as much, where I can see when floor restraints sometimes become some form of a wrestling match, for lack of a better terminology. And then you are risking the staff and the client getting hurt, which we definitely don't want to see. So I guess I can kind of see why the chair restraint would be looked at favorably. But you do have the issue of resources that comes into play, because you can only use certain type of chairs. They can't be rolling. Like, do we have access to that chair when we need it? It could be an issue.
Sure, and I really wonder how that social validity or the acceptance of interventions like plays into this. So I think of like the public perception of restraints, right? So you see someone being wrestled down to the floor. That's not typical, right? It's not something you're going to see as much. No, of course, you're not typically seeing people getting held down in chairs either. But I just think of the individuals within this past study who weren't professionals. How might that look to them? Someone being wrestled down to the floor, it makes sense that it's probably going to look more violent than someone being held in a chair, because, as you said, Brittany, there's kind of less wiggle room. The client is a little more restrained in a particular pose. So maybe just the overall aggression piece and the extreme movements of the client and the staff have a play into the social validity.
Yeah, I would agree with you on that, Alex, that there's just, when it comes to social validity, I think that people in the community, especially those that don't understand ABA, might look at a chair restraint more favorably than those floor restraints where you're sometimes taking a client down to the ground from standing. And that, that can look a little intimidating to someone who doesn't understand what's happening.
Definitely. And I know through like CPI training and handle with care that I've been in, anytime you have to do a floor restraint, it is not fun. I mean, even though we're doing the best that we can ethically, we're ensuring client can breathe. As soon as you hit the ground, it is uncomfortable for the staff, for the client.
Yeah.
So I really wonder, maybe these chair restraints are more effective and maybe they have more of an acceptance because, you don't have your body sprawled out on the floor.
Yeah.
Does anyone else have any other thoughts on the varying types of physical restraints and their effectiveness, or even the social validity of the different training methods?
No, I think that we covered it.
Cool.
Okay, so moving forward from that, we want to look at the characteristics of restraints and seclusion. So what do we think contributes to restraints or seclusion being found ineffective in their use?
So one of the things that came up in the literature was a lack of training would contribute to ineffective restraints and seclusion. So training on restraints and seclusion definitely differ from program to program, institution to institution, and this can dictate whether a particular restraint is used effectively. Lack of training, poor supervision of staff, unclear expectations outlined for the client, unclear expectations and procedures for the staff, failure of reporting systems, and a whole lack of positive interventions, which we have already talked about. All of those things have been found to contribute to ineffectiveness.
Yeah, and also the lack of clinical observations and data analysis. Physical restraints can function as positive reinforcement for some people. And so sometimes, it's maintaining rather than decreasing the behaviors targeted for intervention. Um, and then also, crisis management being used as behavioral treatment plan. ABAI states that crisis management programs should not be a replacement for behavioral treatment plans. Restraints should be used as a last resort, obviously.
All right. Does anyone have any other thoughts or on the factors that make restraint ineffective?
Well, I think it just showcases that, it's not only the physical aspect of the restraint and training, it's also the data collection, the analysis, the understanding of the effectiveness of everything involved. So it's not just merely physical, it also connects to the data, which is, it makes sense, but it's also fascinating to see that, because when we think of restraints, we just think, okay, is the staff member holding them correctly? Is the child thrashing too much? And it's much more than that.
Yeah, and I think that's interesting because it really emphasizes the importance of being technological in our application of restraint, having our operational definitions down, accounting for treatment drift over time, like making sure our IOA is really high up there. I think that those, everything we learn in ABA kind of teaches us about that and how we can make restraint more ethical and effective.
Definitely.
All right.
Yeah.
So moving on, what are the risks associated with restraints and seclusions and in different settings, in schools, other settings? What do we think?
Sure. So I know with restraint and seclusion training programs, there's still obviously flaws that can cause a high level of stress for staff members, for clients. We're seeing a lot of injuries all over the place. We're seeing staff turnover day by day. And unfortunately, sometimes we do see cases of death for staff and clients. And we're seeing that from the literature from Singh et al. They really focus on the negative aspects of these training programs and what needs to be changed. And we're also seeing that there's a lot of care providers that are susceptible to misapplying physical restraints and deviating from the protocols that are set in place. There was some research done by Lewis E. Sperry and Draper from 2015, just noting that there are some legal and ethical slippery slopes that can be activated essentially when people are drifting from the protocol. So it's really important to stay consistent with the training and to ensure that everyone knows what they're doing, and if there are any issues, to get that training going again to ensure consistency and reliability.
Yeah, and just sort of piggybacking off that slippery slope that Alex was talking about, the National Disability Rights Network, the NDRN, cites that there are many cases of misconduct with regard to restraint and seclusion. They cited 50 examples from 38 different states of the mistreatment of disabled children in public and private school settings. So this is kind of a rough list to read, but the researchers LaBelle et al. In 2012 cited that there were examples of children being denied food, children being forced to sit in their own urine, locking them in makeshift seclusion rooms, breaking arms. And then, as we know, several children have died through the use of physical restraint. So I think that slippery slope that Alex was talking about, that deviation from implementation protocols, that's very real and definitely a big risk when we think about these practices being put into place.
We're definitely seeing some of these concerns when it comes to juvenile detention centers as well. And what's happening is these juvenile detention centers are becoming such a huge portion of them are children with disabilities. So it's kind of becoming this catch-all for those kids that are getting left behind in school, unfortunately. And then when they enter the juvenile detention center, there's very few positive teaching opportunities in a lot of facilities. And so they're not gaining any skills through being restrained or secluded. So they're not being taught de-escalation strategies for themselves to avoid being restrained or secluded in the first place. So unfortunately, we were just seeing an increasing number of incidences of the restraint and seclusion, and this happening primarily with a population of children who have severe mental health issues, learning disabilities, autism, things of that nature.
Right, so we're seeing that just relying on these restraints, these seclusions, actually isn't that helpful, right? We have to understand how we can help these individuals to improve. And we're seeing this in the literature, but I also wonder, does anyone have any personal experience with these risks that we're talking about with restraint and seclusion?
I did work in a detention center for a while as a mentor, so I was contracted in. But what can be concerning is that the training on positive interventions typically isn't there. There's no ABA training. They're trained to, like, when this child escalates, like, it's a safety risk, we have to intervene. A lot of times it's a staff who's being threatened in the situation, and so the restraint is being used out of anger and fear rather than as a preventative strategy to keep the child from harming themselves or someone else. It seems sometimes like the staff is just responding in this frustration. And in ABA, you're taught to respond neutrally, and it's a part of a very clear behavior plan, and there's very clear steps outlined before we're ever going to get to this point. So I think that was my concern when I was in that setting of, are there better procedures that could be put in place?
So I've had experience also with restraint, and also seen firsthand some of the risks that can be associated with the use of restraint. About 10 years ago, I was working at a pretty prominent ABA school as a teacher's assistant, implementing behavior plans, running programs, and the use of restraints was, pretty prominent depending on the classroom and the kiddos that you were working with. And something that really stuck with me, which was a little bit disturbing, was when we had sort of a really easy day. There were no big behaviors. And by the end of the day, there was a child who met the criteria for being put into a restraint. And I heard a staff member make a comment about the fact that they had been so bored today and that they were glad that something kind of more exciting had happened, like referring to the fact that that child had to be in a pretty long floor restraint. And that just really stuck with me as the fact that the use of the restraint in some way was acting as like a positive reinforcer for this staff member for coming to work, like that they enjoyed this part of their job. And that was kind of strange to me. It also, I witnessed at that job a lot of stress among staff members, oftentimes injury among staff members, and a really, really high turnover rate.
Right, and that makes sense. If the staff member is so focused on doing restraints, of course there's going to be those negatives associated. I know I worked at a residential facility, a treatment facility, and it kind of makes me think about an experience that I saw where a staff member, in regards to a particular client, would always go for a physical restraint, and more than that, a full restraint. And I remember talking to him later about that, and he would just say, "Oh, you just have to do it with this kid." And yeah, maybe some kids do need particular restraints. We talked about the effectiveness therapeutically of restraints and how learned behaviors adapt over time, but I never really saw that adaptation for that kid. So it makes me wonder, is this a similar experience to what you had just talked about, Heather, where a staff member just wants to restrain a child? And, if so, that seems to be quite unethical.
Yeah, I agree.
Does anyone else have any thoughts about their personal experience with restraint and seclusion and the risk associated?
I think that's it for now. So I think we can
All
move
right.
on to our next question.
All right. So the use of restraints and seclusion, vary from setting to setting. So, um, is it ethical? Do y'all think it is ethical to use mechanical restraints as a way to address behavior if it is not something that can be used across various settings? So, like, what happens if a child has a mechanical restraint in one setting, but then moves to a new setting where that type of restraint is not allowed?
I think we just have to be careful of the all or nothing mentality. Like if we can't use it, if this restraint works for one kid, should we use it for all kids? Probably not. We need to, if you look at the research, you look at the code of ethics, it should be individualized. But then I don't think that it's acceptable either for us to say like, hey, we can use it in this settings, but we can't use it here. So should we just not use it in any setting? I think you get into some tricky things with being able to stay individualized if you're willing to say, since we can't use it in all settings, let's use it in none.
Well, while I can see that, I do think that there are some considerations that should be made about what can be implemented in certain settings. I know that I worked in Minnesota for a couple of years where floor restraints are illegal, and we would have a number of students that would come into our school district who were used to those type of restraints, and we would have to find different options for them. I also, if you think about just the number of settings that somebody encounters throughout their day, if you have a student who we decide that seclusion is the best option for them, and seclusion rooms are not available in every setting. If they're at the grocery store, what's going to be the best option there? So there are some considerations that should be made. I know one specific example of a student that I worked with. She was unfortunately like a self-induced vomiter, and she would do it very habitually after every meal. Unfortunately, she had been hospitalized in the past due to weight loss. And because we had determined that it was at least partially automatically maintained, we had decided that part of the plan was to stop her from being able to successfully vomit, which included a restraint. However, that was not a possibility at home because there was only one caretaker available at home at one time. So, and she required a 2-person restraint. So what ended up happening is that they were kind of like these variable schedules of reinforcement happening. She was being allowed to vomit at home, but not at school. And then also like behavioral contrast, like she was doing it so much more at home following our introduction of that restraint. So taking into consideration the different settings and what was allowed in different settings was definitely important in that example.
Brian, I think it just really speaks to the fact of, the setting matters, the individual matters, and the research that we're seeing, from like the ABAI or Vollmer et al. From 2011 that we talked about before, that pre-planning, that consent, that full understanding of the client and their behaviors really matters. So, if we have mechanical in one setting versus non-mechanical in another, if both work, let's figure out which one is least restrictive, which one works most effectively. And if a particular restraint can't be utilized in a different setting, okay, we're making a new plan. We're understanding what might work, maybe not as effectively, but as effectively as possible for this individual in a new setting. Unfortunately, we can't always control the setting that the child's in. So we have to come to understand what can we control and what can we do to keep the staff and the child as safe as possible. And also, how do we reduce those behaviors over time? What works best for this individual? And I might sound like a broken record with that, but I really think it makes such a difference when we individualize these plans. And we're seeing that in the research as well. So I think that really connects to everything that we've talked about today.
So I think, yeah, I completely agree. And that makes me really think about the fact, all these different things that you guys have brought up about how some settings allow some sorts of restraints and some settings don't, or some settings might not have the correct resources. And like Alex was saying, it's, we have to really look at each setting and each individual. And so I guess my question for the group would be, how do we come up with alternatives to restraints, especially when it comes to there's certain places where restraints are no longer allowed or are not we're not able to use them due to staffing or other resources. So one of the things that we can use that research has shown that antecedent interventions can be shown to be effective in preventing problem behaviors from occurring. So just 2 examples are discriminative stimulus of control and using motivating operations to hopefully decrease those problem behaviors so that you don't need to have a restraint or seclusion.
Right. And then, so going off of that, restraints and seclusions, though, have been found to be effective when used in combination with other interventions, such as, a contingency-based behavior program, skills groups, token economy, those things.
I know it was mentioned earlier, but a fixed time release is another option, or putting a stopping point essentially on a holder seclusion and saying that after this amount of time that we're gonna end that seclusion or restraint, that hopefully would minimize the amount of time that a client is exposed to any physical restraint or seclusion. We also have a visual talking about PBIS within schools and correctional facilities. It's been shown to reduce the number of restraints and seclusion needed when using these positive behavior interventions. And so if you look at our visual, this was from a school-wide behavior or positive behavior strategy that was put in place. And they went from having about 6 holds needing to be used or restraints needing to be used, about the same the following school year. And then once the school-wide intervention was put into place, we're looking at 1 or an average of less than 1. So that's a pretty significant reduction in the number of restraints and seclusion needed by using those positive behavior interventions.
Yeah,
Right.
that's actually really impressive.
Yeah, and I think that's just a big point that's being touched upon is, it's not about the restraints. It's about restraints in the addition of whatever else needs to be used in that environment, right? Whatever it may be, token strategies or different groups, maybe like social groups or therapeutic groups to help these children come to understand their behaviors and how to adapt and minimize them over time. So it's, it's so interesting that our debate about restraints and seclusion has gone past that, right? And there's so much more to this.
Yeah.
Agreed. So that brings us as a group to the end of this debate on the use of restraint and seclusion. So as a group, we're going to just go through and sort of overview everything that was discussed and debated. The first thing that we discussed was the definition of restraint and seclusion and which types are the most ethical. We agreed as a group that the chemical restraint is the most restrictive, but we found that either physical restraints or seclusion may be the least restrictive. And as we discussed a lot, it's really dependent on the resources, the staff, and the child and the behavior. So that one's sort of up for grabs.
We also talked about factors that lead to effective implementation of restraints, which included training and social validity. We also talked about appropriate positive behavior interventions being placed with restraints and seclusion. We debated what types of restraints would be most socially valid, and we talked about if this question should matter. And it sounded like as a group, we agreed that, we do have to look into the social validity of the restraints that we're using.
Right, and in connection to that, we talked about the factors that led to ineffective implementation of seclusion or restraints, and it really goes beyond that training. That's what we found. So, things like not taking data, using a restraint without a behavior plan in place, not analyzing or adapting plans over time. These are all really ineffective measures that aren't going to cause for a positive implementation over time. So it's really about looking at each client, each setting, understanding what's available to you, and trying to be as effective as possible through technological data, and then also the physical aspects of the restraints or the seclusion.
Right. We also, talked about risk associated with restraints in different settings, such as staff turnover, treatment drift, and facilities that provide very few positive teaching opportunities. We also we discussed these issues, and we also provided our own personal experiences.
Yeah, and then towards the end, we debated whether it is ethical to implement a restraint procedure that cannot be used in all settings. And we talked about how you don't want to disregard a restraint procedure in total just because it can't be used everywhere. But there are certain considerations that should be made about settings and what are available in different settings when you're coming up with a plan for a certain individual. And then we also talked about providing alternatives to restraint, such as antecedent interventions, token economies, motivating operations, as well as de-escalation strategies like we mentioned above. All right, I think that brings us to the conclusion of our debate. Thanks everyone for listening. Bye.